good evening, everyone. Today, we're going to continue with the local anesthetic part 2. So today, we're going to talk about isomerism, EMLA and adjuvants, LA toxicity, and IV regional anesthesia, which is a Bier Block for a completion's sake. So we will be dealing with ionization and pKa in depth, as I promised today, which will be the main factor for onset. Okay, a recap on the last class. So classification of local anesthetic, ester versus amide. Ester's the one with only one eye, amide's the one with two eye, the mostly common used LA nowadays, lidocaine, lignocaine, bupivacaine, and ropivacaine. And based on their actions, we have classified in the ester and amide. Esters are very short acting because of their fast metabolism by enzymes, whereas amides are mostly hepatic and metabolism, divided into fast, they can divide it into short, intermediate, and long duration of action, lignocaine, ropivacaine, and bupivacaine. And the important part we have to know about the chemical structure of LA, they divided into three components: lipophilic part, which is essential to their anesthetic activity; intermediate chain, which is important whether the agent is to decide whether ester or amide and got a lot of structural activity relationship; and the hydrophilic part of the LA, which allows the agent to become ionized and water soluble. Okay, we have intermediate linkage, which is ester and amide. So briefly on mechanism of action, recap, it has two mechanism of action, which is direct sodium channel blockade. The unionized lipid soluble form will diffuse across the phospholipid membrane, and in the cytoplasm it get protonated, become ionized because of the change in intracellular pH, and there will be a direct sodium channel blockade, voltage gated sodium channel blockade at the intracellular site at the activation gate, and keeping the sodium channel at the inactive state. Another theory is the membrane expansion theory, which is the local anesthetic directly affects the phospholipid membrane and lipoprotein matrix, causing inactivation of the voltage gated sodium channel. And these are the pharmacological properties of various local anesthetics. I want you all to concentrate on these three, which is the most commonly used. What I want to show here is all of them have a higher pKa more than pH of 7.4. All the LAs have pKa more than 7.4. So they are mostly unionized form at the pH of 7.5 is lower compared to ionized form. In other words, at the pH of 7.4, they are dominantly in ionized form rather than unionized. Relatively, when we compare, lidocaine have a higher unionized portion compared to bupivacaine and ropivacaine, accounting for its faster onset of action, because we need more unionized form so the LA can cross the phospholipid membrane. And we talk about the plasma protein binding. Higher the protein binding, longer the duration of action, accounting for Ropi and Bupi. And lipid solubility, which is account for their potency and also can lead to toxicity, which we can Bupivacaine have the highest lipid solubility, accounting for its highest potency, thus the lowest dose, and also the highest risk of cardiotoxicity as well. So today, as we're going to dwell into ionization and pKa, so this part comes into picture and the next column as well. So just a recap on the dose again. The most commonly used lignocaine, bupivacaine, and ropivacaine. I remember as bupivacaine is 2 mg per kilogram, ropivacaine is 3 mg per kilogram, and lignocaine is 4 mg per kilogram. Bupivacaine or levobupivacaine as same dose, 2 mg per kilogram. You have to know the maximum dose that can be injected as bolus. For bupivacaine is 150. For ropivacaine is 225 mg. For lignocaine, we will talk into with the graph later, lignocaine toxicity graph, and the dose might vary with the addition of adrenaline or epinephrine because of the vasoconstrictor property, reducing the uptake at the site of injection. With epinephrine, lignocaine can go up to 7 mg per kilogram, and bupivacaine can go up to 2 to 3 mg per kilogram. Ropivacaine does not have any added effect with the epinephrine due to its inherent vasoconstrict property. So there is adrenaline is commonly not added to Ropivacaine. Next thing I want you all to know about this, the way the local anesthetic are prepared. They are prepared in percentage form in the vial. 1% means 10 mg per ml. Okay, where 2% means 20 mg per ml. It's over one, and when we talk about 1%, it's 10 mg per ml. 2% is 20 mg per ml. So lignocaine you as a 2%, which is 20 mg per ml. Bupivacaines are presented either 0.5% as a 5 mg per ml. Ropivacaine we can see as a 2%, or we have 7.5% as well. Okay, so we're gonna do this now. So when we look at it, xylocaine or lignocaine are presented in various forms. The one, the injectable form, mostly we see as 2% injection, which is 20 mg per ml. The xylocaine spray comes in 10%, means they have each injection of them, they got 10 mg. Okay, this is 2% contains 20 mg. They can, when they come at 10%, means each spray contains 100 mg per ml. Okay, 10% is 100 mg. Whereas we can say xylocaine gel as well, used in some patient with hemorrhoids and everything, also 2%. Next, we talk about Ropi. Ropi, we have 2 mg per ml concentration or 7.5 mg per ml concentration. So 2 mg, when we talk about 2% becoming 20 mg, so 2 mg will be 0.2% and 7.5 mg per ml will become 0.75 mg, 0.75%. Please make sure you know this in Viva. When student cannot answer this percentage to milligram, it's quite disappointing. Next will be Marcaine, mostly presented at 0.5%. Okay, 0.5% is 5 mg per ml. Bupivacaine can presented as 50 mg in 10 ml, which also goes to 0.5% as well. And then we have Avimarcaine, which is spinal Avimarcaine, also presented at 0.5%, which is 5 mg per ml. Next, because everyone is doing regional anesthesia very actively nowadays, including catheter infusion for regional anesthesia, we need to know the maximum dose for local anesthetic that can be infused per day as well. Also in epidural, we give LA infusion. Okay, so we need to know the maximum dose. The most commonly used infusion is either Ropivacaine or Bupivacaine. So Ropivacaine infusion maximum is 11 mg per kg per day with the max dose of 800 mg per day. Okay, if the person is 100 kilo, doesn't mean you can go on to 1100. It's still maximum in 800 mg per day. Okay, with Bupivacaine having half of the dose of Ropivacaine, 5.5 mg per kg day, and maximum is 400 mg per day. Of course, in renal impairment, there might be a slight decrease in dose. We're not going to go in depth of that. So this is for your day-to-day practice. So another part that for your day-to-day practice that people usually get confused or ask them to prepare is the LA dilution. I'm just going to go briefly on that. How to prepare a specific concentration of LA. The formula is we have to decide what concentration of LA is required. Let's say you need the LA requirement of 0.2%, and based on what is the LA that you available, but you only have 0.5% or 0.7%, but you want a much lesser concentrated LA from a more concentrated LA. So how are we going to do it? The formula is concentration of the LA required. Let's say 0.2% here, concentration of LA available, let's say 0.5% here, and volume of LA required. Usually we prepare up to 50 ml. It's up to you, 20 ml or 50 ml. You put the volume here, and then you will get the volume of LA from this available LA, the concentration LA you have that need to be syringed out. From that, use this volume and plus the normal saline for dilution to make up the total volume of LA that is being required. Okay. Let's do a simple calculation. Let's say we have a Ropi 0.75%. This is very commonly occurs in our practice. We usually have a more concentrated Ropi, but we want to prepare 0.2% for infusion or epidural or so and so. So we want to prepare 50 ml of Ropi 0.2%. How do we do it? First, concentration of LA required is 0.2%. Concentration of LAVF is 0.75%. And we want to make up to 50 ml of Ropi 0.2%. So that will give you a 13 ml of Ropi 0.75%. And then second part is dilution, where you take the 13 mils of 0.75%, add on 37 mils of normal saline, you will get the final concentration Ropi 0.2 mils for a 50 mils of volume. Okay, this is how things happen. Okay, next we move on to ionization and pKa. I hope you all have watched the animation videos that I shared the link from YouTube. If not, after this class, please watch it again because it's very easily explained using animation in video rather than I'm talking and using slides. I'm going to simplify it, but if you watch the video, that's going to make your life even easier. Okay, first we start off with what is pH and pKa. pH defined as the negative logarithm of hydrogen ion concentration, negative log H plus. It indicates whether a system is acidic or alkaline. Okay, these are all keywords. This is what we are saying about pH says whether a system or solution is acidic or alkaline. Higher pH, when the pH is high, let's say it's more than 7.4, we say the system is alkaline. Thus, it contains lower concentration of hydrogen ion. Whereas when the pH is low, less than 7.4, we call the system is acidic, means it has higher concentration of hydrogen ion. Let's move on to pKa. pKa indicates whether an acid is strong acid or weak acid. Okay, pKa. Okay, is a dissociation constant for acid. The A stands for acid. Okay, but we interchange and use it in base as well. So for time being, just concentrate on the acid part. So this is a dissociation constant for acid. When an acid drug is placed in a system, it will dissociate to ionized and unionized form. So this is a dissociation constant to mention whether that acid is a strong or weak acid. And it is also as the pH at which 50% of the molecule or the drug which we talk about is ionized and 50% in non-ionized. What does it mean is this is at pH at which when the drug is placed in a solution, it will dissociate and will come into equilibrium where it presents 50% ionized and 50% non-ionized. pKa is pH at which 50% molecule is ionized and 50% molecule is non-ionized. Whether the acid is a strong acid or weak acid is based on the pK. We'll come into the graph. Okay, all this brings back to Anderson-Hasselbalch equation. As I mentioned, pKa is a dissociation constant for an acid. Follow my mouse here. Dissociation constant for an acid. So when an acid is mixed with water in a solution, it will dissociate to become conjugate base and hydronium ion, which is the ionized part. This is the ionized part. This is the unionized part. Ha is the unionized part, concentration of the acid, and this is the ionized part. Okay, the A minus will be the ionized part. So when we put this parameter into the Anderson-Hasselbalch equation, pH equal to pKa plus log to the 10 of ionized, A minus ionized over unionized form. So Anderson-Hasselbalch equation provides a relationship between pH of acids in aqueous solution and their pKa, acid dissociation constant. This is the pH, this is the pKa. So Anderson-Hasselbalch equation relates these two. Okay, the acidity of a system to the acid dissociation constant. Look, just concentrate here. This same equation can be used for weak base as well. So in acid, this log 10, the ionized part is on top, unionized part is at the down. For base, it will be the other way around, where unionized part will be on top, ionized part will be at the lower part. We'll come into it. Okay, again, Anderson-Hasselbalch equation talks about relation between pH and pKa. First, for a weak acid, we said when an acid is placed in an aqueous solution, it will move back and forth. It means it will dissociate until it reaches an equilibrium where the ionized part and unionized part, the H plus, the A minus, the ionized part and the unionized part are in equilibrium. 50% ionized, 50% unionized. That pH will be the pKa. So this gives us this equation. From that, we can find out percentage ionization of weak acid using this formula. As I mentioned, for weak acid, on top is always ionized, below is ionized plus unionized. So we come into it, don't get confused. For weak base, it's just the opposite. Okay, it is just the opposite. This is again talking about the dissociation into ionized form and unionized form. So BH plus will be the ionized form, B is the unionized form. In the Anderson-Hasselbalch equation, for base, the unionized form will be on top and ionized form will be at below. So the weak base, when we calculate the percentage of ionization, it is reversed. Okay, it is reversed, where for acid is pH minus pKa, whereas for base is pKa minus pH. Okay, it will be pKa minus pH. So again, just a summary, it is the, again, so when we talk about for acid, ionized drug concentration is on top. For base, unionized drug concentration is on the top. There is a mnemonic for it where I remember was taught by my senior. Basically, union is on the top. Let's say you have a company, you have a union. That union have very lot of power. So what I remember is base, basically union is unionized, is on top. If you have ever confused which is on top, which is below, remember for base, basically union is on top. The equation is the same, just this ionized and unionized but differs. For base, basically union is on top. Okay, let's come to a working example. You all can do along with me. Calculate the percentage ionized of a weak acid drug with the pKa of 8.6. This drug has a pKa of 8.6 and the pH, the system pH, the solution, the system is 4.6. So for a weak acid, we know this is the calculation. So when you put in the calculation, you just substitute into this, you will get this, and 1 divided by 1.01 is 0.99%. It means only around 1% or 0.99% is ionized. It means most of the drugs are unionized form. Okay, this is just example. We'll come into it in a while because for you to do all this, you need calculator. It's okay. Just remember, okay, this is how we use the equation if we are given this data. Okay, for primary, this is not very important, but MCI can be asked. Okay, for equipment paper. Let's use it for a weak base. pKa of 8.7 and the system is 7.7. You can look at it. Again, when you use it, it becomes 7.7 minus 8.7. Sorry, for this is a bit of mistake. For base, it's pKa minus pH. Okay, we talked about it here, right? For base is pKa minus pH. Okay, I'm sorry, I think I've wrongly copy paste this one. So this will be 8.7 minus 7.7. So it's 1.1. Okay, 1.1. Okay, that brings us to this graph. Okay, this graph is y-axis is the unionized portion of the molecule and x-axis is the pH. Okay, these are acid. This graph is for, when we talk about this graph is for acids, this graph is for base. Okay, remember this statement. For acidic drugs, when the pH is less than pKa, when the system is acidic, it means the pKa is higher than pH, more drug will be unionized here. Okay, this is pH less than pKa, means pH is becoming acidic, more acidic. The pKa is bigger, more acids are unionized portion. Whereas for base, when the pH is more than pKa, pH is more than pKa, more drugs are unionized. It's the other way around. Okay, so we have talked about unionization. Okay, this graph, the y-axis is unionized portion, whereas x-axis is pH. The graph can be y-axis ionized or unionized. Here we are talking about y-axis being unionized. Okay, I want to show what are the relation with pH and pKa? Causing more unionized fraction. For acid, pH less than pKa, more unionized. You can just remember one statement here. That's what I did. I just remembered this. Acid, pH less than pKa, more unionized. After that, I just work out in my mind for everything else, because after this, everything else is vice versa. What is vice versa? I mean, if you look at it, acid, pH less than pKa, more unionized. So if pH is more than pKa, if pH is more than pKa, more will be ionized. Let's look at it. If pH is more than pKa, acids, more will be ionized. That's why the unionized fraction is lesser, ionized fraction is higher. The graph is coming down. For base, pH more than pKa, more unionized. If it otherwise, if the pH is less than pKa, more will be ionized. Okay, if the pH is less than pKa, bases are more unionized. The unionized fraction is lower. More are ionized, protonated. Okay, this again shows you in a separate graph. Just concentrate on this part yet first. Okay, for this part, as I mentioned, you see in this graph, y-axis is ionization, where x-axis is your pH. Okay, what is pKa? pH at which 50% is ionized, 50% non-ionized. So this is your 50% pKa. So when you draw a graph, if you want to show pKa for a drug, you have to show 50% ionization. Okay, this is for acidic. The graph for acidic is upgoing. For graph for a base is downcoming, but please concentrate on acid first. For acid, when pH is more than pKa, okay, this is your pH, this is pKa. Let's say the pH is being more than pKa. This is your pKa. Let's say the pH is now more are unionized. Follow my mouse. If the pH is here, it is more than pKa, more will be unionized. This is the unionized fraction. Whereas, let's say go vice versa, if the pH is less than pKa, the pH is here, lesser than pKa, less will be ionized, more will be unionized. It's converse for base. For base, when the pH is more than pKa, more are unionized, less ionized fraction. Where it's the other way around. If the pH is less than pKa, let's say the pH is here, pK. This is why I say pKb. For base, they write sometimes pKb. It's interchangeable. pKa also named base dissociation constant. Okay. So when the pH is less than the pK, you can see more fractions are ionized. It's the other way around. Okay. How do I remember the shape of the graph? For acid, I think A goes this way. So it go up. In exam, you might get confused with upgoing or downcoming. So for acid, I remember as such. For base, I remember as such. Upper part is smaller, bigger part is bigger. This is my way of remembering. Up to you. You can have your own way of remembering. For acidic, A, down, upgoing, the way you write your A. Whereas for B, it's downcoming and the bigger part is at the base. So base, B, down part is bigger. A, acid, it is going up and then coming down. It's upgoing the graph, where this is downcoming. This is my way of remembering. I leave it to you all to have your own way. Okay, let's put it in local anesthetic. This ionization concept in local anesthetic. We've already talked about the mechanism of action of local anesthetic, where the LA has to be present in unionized form. Okay, lipid soluble unionized form, so they can cross the phospholipid membrane. PLM stands for phospholipid membrane, and then get ionized, so they can block the voltage gated sodium channel, VGSC. Okay, so what we want to know, as more unionized form present, faster the onset of action. So we look at Bupivacaine versus lignocaine here. The Bupivacaine pKa is 8.1, whereas the lignocaine pKa is 7.9, and the pH is at 7.4. Let's say we inject lignocaine at our tissue and we assume the system is at neutral pH. Our skin is at neutral pH. Okay, pH is at 7.4. pKa of 7.9 is pH at which the drug present in 50% ionized and 50% non-ionized. Okay, if you look at the graph for lignocaine versus for bupivacaine at the pH of 7.4, just concentrate here. At the pH of 7.4, more bupivacaine is ionized compared to lignocaine. In other words, lignocaine has more unionized form, whereas bupivacaine have less unionized form. That's why lignocaine works faster. LAs are weak bases. When the pKa more than pH, pH is less than pKa, more are present in ionized form. The larger the pKa, more ionized form present. Okay, all the lignocaines have pKa higher than pH, neutral pH of 7.4. So if their pKa is even higher, or means further from the pH of 7.4, they will be present more in ionized form, thus they are slower onset. Look at this graph. This shows the pKa versus onset. The one with the lower pKa, thus lesser gap with the pH of 7.4, have faster onset, whereas the one with the higher, okay, the one with the higher pKa, they have a slower onset. Okay, these are esters, these are amide. Okay, that brings us back again to this one, the percentage unionized at pH 7.4. Here we know lignocaine have the highest percentage, 25%, compared to ropivacaine or bupivacaine only 15%. Can we calculate this? Again, we come into this. Please watch the animation video. The fellow showed it in a very simplified manner by actually simplifying the Anderson-Hasselbalch equation. So I'm just going to run through it in a different way here. Okay, we have talked about this weak basic. How do we calculate? Let's do it for lignocaine. At a pH of 7.4, lignocaine pKa is 7.9. So 7.4 minus 7.9, or you can do it other way around, 7.9 to 7.4. It is 0.5. When you put a log of negative 0.5, you get 1.31. Okay, as I mentioned, this is logarithm. When you logarithm, you have to use a scientific calculator. When you put a log of minus 0.5, you will get 1.31. Okay, 1 times 100 is 100. So 100 over 1.31, you get 75% of lignocaine is ionized at the pH of 7.4. So 25% is non-ionized. Whereas for bupivacaine, it is 8.1. So 7.4 minus 8.1 is minus 0.17. Log to the minus 0.7 will get 1.2. 1 times 100 is 100. Divide by 1.2, you got 84% ionized, only 16% non-ionized. This shows lignocaine have a higher percentage of non-ionized molecule, thus it can cross the phospholipid membrane faster and causes faster onset of action. Okay, this is again the same one. So just I want to show you what happened in a situation where your pH, neutral pH of skin or the topical application, the environment is acidic. Let's say for example, abscess. I talked about it in last time. In abscess, inflammation, the environment will be acidic. So when it's acidic, the pH will be lower. When the pH is lower, we have talked about it. Look at it. Your pKa of the La is here. It is acidic. The pH is even lower than the pK. Thus, more it will be present in a lower. You can see it's present more in a ionized form. Okay, let's say we use it only for lignocaine here. Here we compare two drugs with different pKa. Here we're going to compare only one drug with same pKa. Let's say lignocaine at a pKa of 7.9. Just put it here, 7.9. In an acidic situation, at the 7.9, if the pH is 7.9, it's 50. But if the environment become acidic, it will be more ionized. That's why it's slower onset, lignocaine. That's why in abscess, it is not wise to give La. But if we add on bicarb, if we inject bicarb around the abscess area to make the environment become alkaline, the pH will be higher. Thus, the pH is more than the pK now. So, more unionized fraction will be around. ionized fraction will be lower. This is how you look at this graph. If for the same drug, if the environment changes from acidic to basic, the ionization percentage will change as well. I hope this is you all can understand this concept. You all have to read about on your own as well after my explanation to understand, and please watch the video. The video actually makes it much more simpler. Okay, I don't want to copy paste from the video, that's why I made it on my own. Okay, we have talked about pK and ionization. Next, go into the few more concepts of LA. Another famous question or short note can be asked in LA is about isomerism in LA and their clinical application. And when we talk about isomer, the main two drugs that will be talked is whether about Ropi and Bupivacaine and their differential pharmacokinetic profile, especially in their toxicity profile. And a brief note can come out on LA adjuvants as well. Okay. First, isomerism in LA. All esters, we have LAs for esters and amide. All the esters are achiral. We have if you don't know what's chiral, you have to watch a video on isomerism. I've done a topic on that, or please read about isomerism. Chiral centers are centered with 4 different groups attached to them. Okay, one atom which is attached to 4 different groups. That is the chiral position. Okay, esters does not have chiral center, so they are called achiral. All the amides, okay, all the amides are enantiomers, thus they are chiral, except lignocaine. Lignocaine is achiral. All the amides are enantiomers. They present as a chiral center. They do possess a chiral center, except lignocaine. This can come out as SBA or MTF. Okay, these are all facts. When we talked about enantiomers, we have S and R enantiomers. R enantiomers have greater potency for blocking both neuronal cardiac voltage gated sodium channel. Okay, it means R enantiomers have greater potency to block the channel. Thus, they have higher potential for therapeutic efficacy and systemic toxicity. In other words, R enantiomers are more potent, and also when they are potent, they can be more toxic. R enantiomers, whereas S enantiomers are less potent, but they have a better toxic profile, but their potency can also differ. So what is very important about knowing this R and S enantiomer, they have different PK/PD profile because of differences in interaction with voltage gated sodium channels. Okay, we come into a clinical application now. This is just the introduction of LA in with isomerism. So a brief intro, what is enantiomers and racemic mixtures? Enantiomers are chiral molecules that are non-superimposable mirror images of each other. What is superimposable? If we have a 2 identical mineral water bottle, if you put them, rotate them in the same plane of polarized light, you can superimpose them. Where what is non-superimposable, it is your N. It may look similar, but you can't superimpose them. Okay, it will be a different image. A racemic mixture contains 2 enantiomers in equal amount. If, let's say, look at this water bottle, if this is present in 50%, this is 50%, that is called racemic mixture. If this present in this, there are two type of this bottle, this is only one bottle, that is not racemic mixture. Okay, you have a mirror, you look at this is the chiral center which has 4 different groups. H, R, NH2 and COH. All these are 4 different groups attached to it. So this is a chiral center. They are superimposable mirror images. You just rotate it, superimpose it from here to here. From here to here, you will get exact same image. Okay, rotation of the plane polarized light. This is what we talk at levo or dextro. I'm not going into that. This is a new way of mentioning it. S versus R. R is right-handed side of rotationness, where S is the left-handed side. As I mentioned, R is more toxic compared to S. Okay, cardiotoxicity, R bupivacaine more than S bupivacaine. As go to emergence delirium also. S ketamine more than R ketamine. Okay, but they are more potent. S ketamine is more potent. Okay, emergence delirium. That is why they have more delirium. It means In terms of ketamine, the potency is higher. That's why we use S-ketamine. They are super high. You don't have to give high dose. It's okay. Don't think about the ketamine now. We talk about only LA. That brings us to chirality. As I mentioned, this is the chiral center with 4 different groups. When we rotate it, you'll get the exact same image. In LAs, all the amides, esters, we already said they are not chiral, whereas amides, they all have chiral center except lignocaine. Lignocaine does not have a chiral center. This is the chiral center, but it does not have 4 different groups. It has 2 similar groups, H and H. That's why this is not a chiral center. So except lignocaine, all other amides possess a chiral center. So S enantiomers, we have mentioned R enantiomers are bad, S enantiomers are good. Okay, so S enantiomers are, how do I remember they are good? S stands for super. Super means everything is good lah. Okay, so they block neuronal more than cardiac voltage gated sodium channel, lower potential for cardiac toxicity. Whereas for R enantiomer, they actually equally block both neuronal and cardiac voltage gated sodium channel. We want our LAs to block neurons. We want to block the action potential conduction, not the cardiac action potential conduction. We want to block the neuronal action potential conduction. Okay, so we want the LAs to work more on the neuron side rather than the cardiac side. Whereas the R enantiomers actually have affinity to both neuronal and cardiac. So that's why S is better. And S enantiomers also have enhanced vasoconstriction. Okay, there's S enantiomers of the LA like S and Bupivacaine. They have enhanced vasoconstriction. Thus, Bupivacaine is presented as a racemic mixture S and R, but Ropivacaine is only presented pure S enantiomer. Okay, Bupivacaine we have racemic mixture which has S and R, but Ropivacaine is only prepared. This is what I'm saying is what is formulated. What are the drugs we are getting? Bupivacaine we can get as in S and R. S is the levobupivacaine where R is the normal marcaine. Whereas Ropivacaine is prepared as the pure S enantiomer. The Ropi that we are seeing is only prepared in S. We don't get the R Ropivacaine. So S Ropi and levobupivacaine, which is the S Bupivacaine, is pure S enantiomer. Okay, we have Bupivacaine both S and R. S is the levo, R is the normal marcaine. That's why levobupivacaine better than a normal marcaine. That's why levobupivacaine is preferred in epidural infusion, in peripheral nerve blockade and everything. But whereas for Ropivacaine, we don't have to worry about that because the Ropivacaine that we receive is all pure S enantiomer, which is called as enantiomer pure. Because they're prepared only in one enantiomer, they call enantiomer pure. S Bupivacaine, levobupivacaine, less cardiotoxicity than R dextrobupivacaine. As I mentioned, they have less tendency for cardiac voltage gated sodium channel. Thus, they have a higher CC-CNS ratio. Higher CC-CNS ratio means less toxic profile. I will come into it in a while. Whereas, so in summary, S enantiomers are less toxic, but they have long duration of action because of the enhanced vasoconstriction, reducing the systemic uptake at the site of injection. So again, this is again to talk about Bupivacaine versus levobupivacaine. So Bupivacaine will be the R enantiomer, levobupivacaine will be the S enantiomer. You can see levobupivacaine allows a greater hemodynamic stability with a normal QT interval, while Bupivacaine affect QTC measurement times more. Okay, it prolongs the QT interval. As such, we believe that levobupivacaine may be a better alternative Bupivacaine during clinical fatigue, particularly in patients with cardiac problem. That is why in epidurals and peripheral nerve blockade nowadays we mostly use levobupivacaine whenever it's available. Okay, next, the differences between Bupi and Ropi. Here we talked about Bupivacaine and levobupivacaine. Now we talk about Bupivacaine versus Ropivacaine. Main differences because of the pure enantiomeric S-Ropi, enantiomer pure, improved toxic profile and lower lipid solubility. Okay, when they have a lower lipid solubility, it means their potency is lesser. Your potency determined by your lipid solubility. Okay, when there are less lipid solubility, less toxic as well. Lower lipid solubility means there are reduced penetration of the large myelinated A beta motor fibers, you get motor sparing. Okay, let's say you are giving epidural infusion for two patients. One patient is receiving Ropivacaine infusion, another person is receiving Bupivacaine infusion. Since Bupivacaine has a very high lipid solubility, they can penetrate all types of motor fibers, all types of fibers. We have talked about differential blockade of LA last week. The LA blockade is based on the motor fibers diameter, okay, and velocity. They are diameter dependent as in velocity dependent. Also myelination plays a part as well. Usually LAs will block they will block the smaller fibers first. Smaller fibers or myelinated fibers because of the velocity dependent. Then they go into bigger fibers and non-myelinated. Okay, so when we give Ropivacaine, they have lower lipid solubility. They have lesser penetration of the large myelinated A beta fibers, which accounts for motor activity, thus less motor sparing. Okay, they have more motor sparing, but when you go in continuous infusion, they will slowly block the A beta fibers along with the unmyelinated C fibers. So initially they will only cause pain and temperature blockade. Later on they will go to motor blockade. Compared to Bupivacaine, where we'll give both immediate, as we see in spinal, it is very fast. Okay, let's say you are giving spinal, instead of Marcaine, if you give Ropivacaine, you will give the motor blockade later compared to your sensory blockade. But since we use Bupivacaine in spinal, that's why we give motor and sensory blockade quite fast. But that also, that day we discussed differential blockade based on the autonomic fibers and non-autonomic fibers. So motor block by Ropi is slower in onset, less dense and shorter duration. So it is more appropriate than Bupi for epidural infusion or any peripheral nerve blockade infusion if you are putting a catheter, due to its sensory and motor discrimination and greater clearance. What you mean by greater clearance is faster offset. This is what we want. Let's say a patient receives a labor epidural. The baby is delivered, everything is okay, she's comfortable. When you off the infusion, you want the patient to recover from the sensory and motor blockade faster, rather than they take a longer time to wait the symptom to wean off, fade off. Okay, that is what we say Ropi is better. Okay, Ropi will give a motor sparing. Patient will not have pain, but they still can ambulate. They are not getting motor blockade. They are not getting muscle weakness. And when you off it, the effects fades off fast, and patient can be recovered to normal position faster. Okay, this is what I mentioned about the differential blockade based on the nerve fiber. Here, what we mentioned, Ropivacaine, when initial dosage unable to block this, they will block the C fibers first. But on continuous infusion, they will block the A beta fibers and delta fibers as well, A alpha and A beta fibers as well. So thus causing, I think there is a slight typo here. This is A beta to A delta. This is A alpha. Okay, sorry, A alpha, not A beta. So A alpha fibers. Okay, but that day when we talked about, we say we already discussed why B and C, despite B being much smaller or almost similar size, why B getting blocked first? Because of the myelination. That's why when you give spinal, patient develop hypotension first, because B fibers are for autonomic. You get sympathetic blockade first, then only patient actually have pain and temperature blockade. Okay. This is from Matthew Ho. He has done a very good comparison in talking about the safety profile of Ropivacaine compared to Bupivacaine. He has summarized what all I've mentioned in a table, as in isomerism. Okay, Ropivacaine is a pure S enantiomer, whereas Bupivacaine is a racemic mixture of R and S. R enantiomer have increased lipid solubility and increased toxicity. That's why Bupivacaine has higher toxicity. They are not comparing Ropi and Levo. This is no Levo Bupivacaine. This is pure Bupivacaine. Okay, that is why R enantiomer. Okay, if it's S, that will be Levo Bupivacaine. And lipid solubility, it has mentioned, is talked here, and vasoactivity also has been talked. More vasoconstriction and vasodoses, so less systemic uptake, so less systemic toxicity. Clearance is faster, so faster offset. And cardiac receptor action, the affinity, mean Ropivacaine has less affinity to cardiac cells, so there will be faster dissociation or less blockade of the cardiac sodium channel compared to Bupivacaine. Okay, that's about isomerism in LA. So when you want to talk about isomerism in LA, you have to talk about mainly about Bupivacaine versus levobupivacaine and Ropivacaine versus Bupivacaine. That is your clinical application. Okay, next we move on to the concept of adjuvants for LA. It's either called as adjuncts, adjuvants, additives, anything is acceptable. So what is the understanding is that there are something is added to local anesthetic to improve the action or reduce the toxic profile, increase the duration of action, increases the onset, means faster onset. Anything to make the LA works better and safer. First, we can divide this adjuvant based on their mechanism or the way they act to make the LA better. First, by making decreasing the uptake at site of injection, we have adrenaline, which is a vasoconstrictor. It is added in the dose of 1 in 100,000 or 1 in 200,000. Okay, it can be added to a local injection. It can be added to epidural top up. It can be added to peripheral nerve blockade injection as well. It is added to lignocaine and bupivacaine, not to ropivacaine, because ropivacaine already have an inherent vasoconstrictor property, and experiment shows adding adrenaline to ropivacaine does not have any added benefit. So usually we only add to lignocaine and bupivacaine. If you don't understand what am I talking about vasodilator and vasoconstriction inherent activity, please watch the LA part 1 video. I've talked about the vasodilator component related to LA. So vasoconstriction means it prolongs the action, which is the alpha 1 action of the adrenaline. So no added effect when added to ropi, inherent vasoconstriction. Safety doses increases, lignocaine from 4 to 7 milligram per kilogram. I've talked in the earlier slide. Bupivacaine from 2 to 3 milligram per kilogram because of the reduced systemic uptake from the site of injection. This adrenaline also direct stimulation of alpha-2 adrenoreceptors. It means alpha-2 agonists as go to Presidex or what. So they have a minor inherent analgesic action as well. So they are adding to LA action, as in for analgesia. Next, by changing the pH or pKa, they are making the onset faster. That will be sodium bicarbonate, especially in a site where acidic, as in abscess area, or sometimes occasionally in epidural as well. A patient who have already in labor, in pain, you want to give your epidural labor, you want it to act faster. There are some teaching or school of thought who adding sodium bicarbonate to the initial bolus of LA to increases the make the onset faster. Honestly, I never done it, or I have never seen anyone doing it. I've just heard about it or read it somewhere. Okay, so what does it do? By adding sodium bicarbonate, you are making the ambient pH, the tissue pH, more alkaline. Alkaline means the pH is high, closer to pKa. We know all the pKa of LAs are more than pH of 7.4. So when you increases the tissue pH more than 7.4, the gap between the LA pKa and the tissue pH becomes smaller. So more unionized form available based on the graph that we have learned. More easy diffusion or faster diffusion, rapid onset of action. Okay, especially in acidic environment, like LA for abscess or occasionally in epidural. Next, by increasing the baricity or weight of the LA, making it hyperbaric as we do in our spinal. What we do is adding glucose or dextrose at 80 mg per mil. Dextrose 8%, 8 mg per mil to a spinal avimacaine of 5%, 5 mg per mil, making it hyperbaric, usually done in neuroaxial block, spinal and subarachnoid block. What they do, the added benefit are control the level of block. Because of the hyperbaricity, gravity effect, we avoid I spinal. It also makes the block more dense for the lower limb. It is also causes less sympathetic blockade. It doesn't go up above the T6 or T4, so less sympathetic blockade or less side effect in that terms. Next, synergism, drugs that causing LA effects to be much efficacious and more better by reducing their need for higher concentration, such as alpha-2 agonists, dexmedetomidine or clonidine. Alpha-2 agonists, their works at supraspinal and spinal level, and also dexamethasone and opioids. Opioids are usually added in ITM or intrathecal fentanyl as well. What they do, they enhanced or cause a more dense block. They increases the duration of action of the block, especially your dexamethasone or alpha-2 agonist, or they also causes inherent analgesic action. Okay, we know dexmedetomidine or clonidine also are analgesic. Dexamethasone also some analgesic activity as well, and of course opioids are analgesic. So they work hand in hand with LA to improve their action, as in synergism. This is a summary of it. I got it from Oxford Handbook. I just leave it here with extra few more information regarding their dose and so and so. I will leave it there. They will always mention about hyaluronidase, which is used in ophthal local anesthetic. I didn't talk about it much because I never used it. This is usually by ophthalmologist. This is again another summary of this. There are some school of thought where adding ketamine, neostigmine or midazolam to LA as well, but usually not commonly practiced. This is just for extra knowledge. You don't have to mention it. Usually for short notes, keep it to simple, commonly used, such as adrenaline, opioids, glucose, and what you see in your day-to-day life. Okay. Next concept, short notes can come out on LA toxicity. They can start off with CC-CNS ratio. Next, go to LA systemic toxicity, and finally, we will talk about EMLA and also IV regional anesthesia, Bier Block. So LA systemic toxicity, known as last. The incidence is quite rare, but if it happens, it can be very, very fatal. So LA toxicity, it always need to understand the concept of CC-CNS ratio. What does it say? It is plasma concentration of LA required to cause cardiovascular collapse, CC, versus concentration required to cause CNS symptom, CNS. So this is the definition of CC-CNS ratio. It is the plasma concentration of LA required to cause cardiovascular collapse versus concentration required to cause CNS symptom. It is the ratio. If the ratio is lower, it means toxicity is higher. It means at a lower ratio, at a lower plasma concentration, this cardiovascular collapse can occur. I mean, this LA is more toxic. That is how you understand this. What we talked about the CC-CNS ratio, we need to know about the symptoms of CNS versus CC, cardiovascular collapse. The CNS symptoms exhibited first, then followed by the cardiovascular symptom. So what is central nervous system symptoms? They bind to central nervous system neuron, sodium channel, producing a biphasic effect. They have a two effect, biphasic, two phases. Initially is excitation, initial excitation causing twitching and convulsions. Later on is a delayed depression causing coma and respiratory depression. Patient going into apnea, loss of consciousness and apnea. Whereas CVS, the amide allase like Bupivacaine, they bind to cardiac myocyte fast sodium channels and block them in their inactivated state. They also act as in a type 1B antiarrhythmic. We know allase can be an antiarrhythmic, especially lignocaine, right? By prolonging RP, PR, and also QRS interval. Okay, RP stands for refractive period, not ECG. They are prolonged the refractive period, PR in ECG, PR interval in ECG, and QRS interval in ECG as well. So the CNS toxicity does not always immediately goes into tonic-clonic convulsion. At a milder concentration or lesser concentration, that occasionally you might have encountered in your day-to-day practice when the patient given spinal, lie down a slight eye spinal, they can develop a circumoral or tongue numbness, or patient with epidural infusion, or patient who get a brachial plexus or interscalene infusion, they'll develop the circumoral and tongue numbness first. This is the earliest signs of toxicity. Tinnitus, nystagmus, or dizziness. This is not even gone into your biphasic yet. This is the earliest signs and toxicity of CNS. Later on, they go into biphasic, where they become restless, tremor, tonic-clonic convulsion, and further on, they will go into a depressive state where loss of consciousness and apnea. Whereas for CBS, LA exerts a dose-dependent negative inotropy, higher lipid solubility, more toxic. So that's explained Bupivacaine being higher lipid soluble, they have more toxic. Why? When you have a higher lipid solubility, you have more strong and more affinity towards the cardiac voltage gated sodium channel. And once you bind, it takes longer time from you to dissociate from the cardiac myocyte sodium channel. So stronger binding and slower dissociation account for a higher toxic profile of Bupivacaine compared to other LAs. The arrhythmias can be AV block, prolongation of PR interval, broad QRS complexes, and VF and cardiac arrest as well. So this graph shows the CC-CNS ratio. Don't worry about the etidocaine. Just look at the lidocaine and bupivacaine, the white and the red one. First, we talk about the convulsive dose, which is the CNS dose. Look at this lidocaine versus bupivacaine. A very higher concentration of lignocaine compared to CNS for bupivacaine is needed to elicit CNS symptoms. Same goes to cardiovascular. The lignocaine have a very high safety margin. It means up to 35 mg per kg have to be infused for patient to develop cardiovascular collapse for lidocaine, compared to bupivacaine at 10 mg per kg, they can already start developing cardiovascular collapse. So this graph explains the same. This is the line of toxic symptoms for lignocaine as the serum concentration increases. For lignocaine, it occurs at a much lower concentration. Okay, it occurs even at a faster rate with the increase in concentration. The CC-CNS ratio for lignocaine is higher. Higher ratio means more safer compared to bupivacaine, which has a lower ratio. It means more toxic. So the numbers that you have to know to keep it simple. Earlier we said the dose is 234. For CC-CNS ratio is 357. This is how I remember. Bupivacaine have a lower CC-CNS ratio being more toxic. Lignocaine have a higher CC-CNS ratio being more safer. Okay. Example. This is just an example for you to understand CC-CNS ratio. This is not the actual dose. Actual dose, you need to look at the graph. What I'm saying is just an example to understand CC-CNS ratio, because when we ask students to explain CC-CNS ratio, they don't understand the concept. So what is CC-CNS ratio? Let's say for lignocaine, the CC-CNS ratio is 7. Okay. If you started infusing lignocaine to a patient is receiving lignocaine infusion, and patient already received 50 milligram at 50 mg, 50 milligram. At a dose of 50 milligram, if patient already started developing central nervous system symptoms, it means 7 times of the 50 milligram, 7 times 50, 350 mg. At 350 mg, they are likely to develop cardiovascular collapse. That is what CC-CNS ratio. Okay, it is at 50 mg if they already develop central nervous system. 7 times of that dose that they started eliciting central nervous system symptoms, they will develop cardiovascular collapse. That is the concept of CC-CNS ratio. Hope everyone understands. Okay, regarding lignocaine toxicity, actual values and the symptoms, it is not needed, but you have to know roughly what are the symptoms that can occur at increasing plasma concentration of lignocaine. This is the plasma concentration as serum concentration of lignocaine, and what happens from the initial concentration up to higher. So the value you have to remember is above 25 microgram per ml of serum concentration. Above 25 microgram, patient will have cardiovascular collapse. Okay, above 10 microgram, you will start developing unconsciousness. Okay, loss of consciousness occurring at the 10 microgram per mil. Okay, and respiratory arrest occurs at 20. I remember only 3. 10 is loss of consciousness, 20 is respiratory arrest, 25 ventricular arrest, means cardiac arrest. 10 microgram per mil for loss of consciousness, 20 for respiratory arrest, 25 for cardiac arrest. Same goes here. 10 for unconsciousness, 20 in between is for respiratory arrest, and 25 is for your cardiovascular compression, depression. So apart from that, the other things are just example. You will not be asked to draw this exactly, but if you asked to draw, you just have to mention these 3 values enough: 10, 20, and 25. The others you can roughly mention. Okay. The value of serum lignocaine concentration of 1 to 5 is the antiarrhythmic level. Okay. What are the factors that affect the systemic toxicity, local systemic toxicity? We can divide it into 3 components. First, factors affecting systemic absorption. When you give an LA, how fast it can be absorbed, it based on the site of administration. We talked about it in the previous class. The different sites of administration have different vascularity, thus increasing systemic absorption. Intercostal injection have a higher systemic absorption compared to epidural, compared to brachial plexus, subcutaneous versus topical. Okay, there is a table that I've given in the previous class. And total LA dose and peak plasma concentration, this based on how much you inject and how fast you inject. Next, rate of administration, faster rate, increased risk of toxicity. So these are the factors that affect systemic absorption. Next, we can divide it into the agent factors affecting toxicity. These are the individual agent pharmacokinetic profile. Lipid solubility, Bupivacaine higher being than Ropi than lignocaine. Intrinsic vasodilator activity. Okay, Bupivacaine have a higher vasodilator property compared to Ropivacaine, so they can easily absorb into systemic circulation, where Ropivacaine will stay at the site. And addition of adrenaline, vasoconstrictor. Protein binding, higher protein binding, less free drugs, more action. More protein binding, they will be in systemic circulation more. Isomerism, we talked about R versus S enantiomer, R enantiomer being more toxic. Metabolism and elimination, drugs that are faster metabolism or greater clearance, less effect. Ropivacaine have a greater clearance than Bupivacaine, so less toxic as well. Patient factors affecting toxicity. Now we're going to patient profile that can cause increased likelihood of developing toxicity. Patient with liver failure, heart failure. This is what I mentioned. Your amide LAs are being metabolized in your liver, so by oxidation. So that's why if you have a liver failure, the LA might not be metabolized and get cleared fast, so they can risk of accumulation. Also, renal failure is not included yet. Renal failure as well, because this is renal failure. Because renal failure, your LAs metabolites are excreted via urine. So renal failure, you need to have dose reduction. And condition where your hemodynamics status is deranged, like acidosis, electrolyte derangement, hypoxia, and hypercarbia. What this is important, they all affect your ionization. All these going to affect your tissue pH or serum pH. Thus, it's going to affect your ionization. Pregnancy, in pregnancy, there's less alpha-1 acid glycoprotein. It means less protein binding, more free drug, so they can cross the placenta. Fetal ion trapping, we discussed about it. Compared to maternal pH, fetal pH is more acidic. So once they have crossed the placenta, reached the fetal pH, they become ionized. Once ionized, they cannot cross back to maternal pH. They may stay in fetal circulation and causing toxicity. And elderly, being a less volume of distribution, less protein binding, and less clearance, potency of more accumulation of LA. This is the AAGBI safety guideline. I'm sure all of you have seen it before. I'm not going into it in depth Basically, any toxicity is symptomatic treatment versus definitive treatment. You always go your symptomatic treatment, stop injecting the LA, do your ABC, do your ACLS thing. In patient with circulatory arrest, go for CPR and do your ACLS. Patient without circulatory arrest, do conventional therapies to treat your hypertension, bradycardia and tachyarrhythmia. And then the definitive treatment being the intravenous lipid emulsion. So that you have to know in detail about intravenous lipid emulsion, including the dosage. Okay, the ACL, the symptomatic treatment part, I'm not going to deal in depth. We're going to talk about the definitive treatment, intravenous lipid emulsion, this part. So intravenous lipid emulsion, you must it must be available in each hospital. There must be a LA toxicity card, and it is given with this algorithm there as well. So I will go into the pharmacokinetic profile of IV lipid emulsion. I just want to show this GBI template first. It is a 20% lipid emulsion. You have to give first dose 1.5 ml per kg over 1 minute. Then you have to start an infusion 15 ml per kg per hour. It is the same as 0.25 ml kg per minute. 15 ml kg per hour is equivalent to 0.25 ml per kg per minute. Some books mention this, so don't get confused. It's the same. You can either mention this or mention this, no problem. So you give a bolus of 1.5 ml per kg over 1 minute, followed by infusion. And after 5 minutes, you reassess the patient. You can give another 2 maximum repeat boluses. Okay, you can give another 2 boluses maximum if the cardiovascular stability has not been restored or adequate circulation deteriorate. It means patient is not improving. Okay, in between 5 minutes. For first 5 minutes, you see patient not improving, you can give another bolus, or if not improved, you can give another bolus. So maximum only 3 bolus. And then if after each bolus you have to double the, let's say after this, if still not, you have to increase the infusion rate from 15 ml to 30 ml per kg per hour. Bear in mind, maximum cumulative dose is 12 ml per kg per hour, kg per day for a patient. Okay, maximum cumulative dose is 12 ml per kg per day. So this is the maximum cumulative dose for a patient. So pharmacokinetic profile of a intralipid 20%. Mechanism of action, you have to able to say at least lipid sink in example. The other two are added mechanism, which is also hypothesis. What is lipid sink? When you give such a high concentrated lipid into your serum, you inject IV. Okay, there's an intravenous use. Your serum or plasma is very highly lipid concentrated. And we know our LAs have higher affinity to with lipid. So when, let's say, a patient is receiving Bupivacaine and now develop cardiovascular collapse, it means the Bupivacaines are attached to voltage-gated sodium channel in cardiac myocytes. They have higher affinity there, so they are attached to the sodium channel there. So when you give a higher lipid concentration of 20% into the serum, they causes an attraction of this Bupivacaine out of the cardiac myocyte into the serum towards a higher lipid concentrated region. So that is what we call a lipid sink. Next, exogenous energy source. Cardiac myocyte uses fatty acids as your energy source, in which Bupivacaine also can impair this mechanism of fatty acid utilization as energy. So when we give intralipid, they act as an alternative energy substrate. Okay, because LA inhibit fatty acid metabolism by cardiac myocytes, so the fatty acid cannot be utilized by the myocytes. So now we are giving exogenous energy source. That is one other hypothesis. And another few hypotheses is the intralipid also possess some kind of positive inotropic effect, and they also directly prevent the inhibition of voltage-gated sodium channel by LA. So these are all hypotheses. If you're able to mention lipid sink is more than enough. The other two are extra information. So these are from Nysora, a bit more simplified version from the AAGBI, just only talking about, so when you have a systemic toxicity, your supportive treatments, support ventilation, life support, ACLS, or stop seizures by using midazolam, and then they directly go into your lipid emulsion therapy, 1.5 ml per kg over 1 minute, start an infusion of 0.25 ml per kg per hour, per minute, or 15 ml per kg per hour, assess cardiovascular instability, repeat your boluses, if hypotension still persists, double your infusion from 0.25 to 0.5 ml per kg per minute, and you can repeat it again. Okay, you have to at least continue infusion for 10 hours at least. Okay, monitor for, and you have to monitor for 12 hours at least. And ACLS in LA toxicity, you cannot stop CPR until and unless you know your LA concentration or LA toxicity has been withdrawn. Okay, because it's a totally reversible cause of cardiac arrest. Okay, that is why the intralipid emulsion is very important, and you have to continue the infusion. Okay, once the patient, if the patient is still in cardiac arrest, you have to continue the CPR and continue all your supportive management along with your definitive management. Okay, next, we will very briefly talk about EMLA and intravenous regional anesthesia. EMLA, presented as a 5% cream. It is a combination of a 25 milligram of lidocaine and prilocaine. First, in exam, you will be asked to talk about what is EMLA. What is a eutectic mixture? The definition is eutectic mixture is a mixture of two LAs. Here I'm directly going into local anesthesia. EMLA is a mixture of two LA, eutectic mixture of two local anesthetic, at a ratio that produces a substance with lower temperature melting point. So this is what we want to achieve. We mix two LA, so at the end product we'll have a lower temperature melting point. Means individually lignocaine and prilocaine will exist as solid, crystalline solid, but we want them to exist as oil at room temperature. So by mixing them two in a right proportion, at the end product will be a lower temperature melting point, so they can exist as a oil at room temperature. EMLA 5% presented at white oil water emulsion. Okay, white oil water emulsion like a oil. It contains 2.5% lignocaine, which is 25 mg, and 2.5% prilocaine, which is 25 mg. Okay. By achieving this oil water emulsion with a lower temperature melting point, they don't need solvent. They become a very higher concentration. So by fixed law of diffusion, they have higher concentration, faster intake, faster onset of action. EMLA 5%, they are local anesthetic droplet in water emulsion. This is an extra point. They have sodium hydroxide added to increase the pH, as we talked about, as same goes to sodium bicarbonate. To making it more alkaline, we have more unionized portion. Melting point is lower, 18 degrees Celsius to present as oil. The dose is 1 to 2 gram per 10 cm square, because we're going to apply it topically, surface area 10 centimeter square. If you don't remember this information, is more than it's okay. The onset is quite fast, but not immediate. It took around 5 minutes. Maximum effect lasts from 45 minutes to 60 minutes. Okay, this is the new information that I got to know a few days ago when I do slide. I know it is available as a 5% cream. I got to know that they are available as a dermal patch as well. I don't think it's available in Malaysia, but I saw that online. They actually they do formulate it as a dermal patch as well. Users to numb skin before IV line or harvesting skin graft. They also applied to intact skin. Why I do highlighted or put in red intact skin is, for you to apply EMLA, the skin cannot be break. It is not applied on a mucous membrane. It has to be applied on intact skin. Otherwise, it will be a higher rate of systemic absorption. 25 milligram is very high. 5% means 50 milligram. It's very high concentration. Systemic uptake will be very high. So it has to be applied to intact skin under an occlusive dressing. It means you cannot just apply EMLA and leave it. What you're supposed to do is when you apply EMLA, put a tegaderm on top. So it stays there and it becomes concentrated there. At least 60 minutes prior procedure. Cautions, you have to worry about methemoglobinemia, especially in infants less than 12 months old, because they are deficient in enzyme called methemoglobin reductase. Okay. Why do they develop this methemoglobinemia? Because of this culprit of prilocaine, not the lignocaine. It is the prilocaine and a metabolite of O-toluidine. This O-toluidine is an oxidizing agent. which can change hemoglobin hemoglobin to methemoglobin. I will come into it. So that, and another thing, caution, do not directly apply it on mucous membrane, high systemic uptake. And there are some drug-drug interaction has been noted as well, especially in antiarrhythmic like phenytoin. They can cause synergism. So sometimes synergism in antiarrhythmic can be disastrous. They can be a toxic as well. Okay. If you can able to mention methemoglobinemia and systemic uptake is more than enough. A bit more detail on the methemoglobinemia, a bit extra knowledge. What is methemoglobinemia? Your normal blood become a chocolate colored blood because of high concentration of methemoglobin rather than the normal hemoglobin. So what happens is, this is your prelocaine. When it metabolites, it become O-toluidine. That is the metabolite of prelocaine. Follow my arrow here. So this O-toluidine is the oxidizing agent. So what it does, our hemoglobin, our iron present in Fe2+, okay, ferrous form, this is ferric form. Okay, when your Fe2+ being oxidized to ferric form, Fe3+, they become methemoglobin. This is the adult HB hemoglobin, which is good. This is the non-functional or less functional hemoglobin, methemoglobin. O-toluidine being oxidizing agent, oxidize the Fe2+ to Fe3+, causing hemoglobin to become methemoglobin. So your ferric or oxidized form has a reduced ability to bind to oxygen, where our ferrous form, which is the normal form, binds to oxygen easily. So this ferric form reduces oxygen carrying capacity of your hemoglobin. So how do we know? The clinical picture is patient will develop cyanosis, especially when your methemoglobin level goes higher than 3.5 milligram per deciliter. Extra information lah. Okay, when it's more than 3.5 milligram per deciliter methemoglobin, you will develop cyanosis. It does not improve with supplemental oxygen, because how much oxygen you give also, the oxygen carrying capacity of hemoglobin is reduced. But when you do a ABG, the oxygen saturation normal because of normal PO2, but pulse oximetry will be low, 85%. This is your low PO2. The error in pulse oximetry, one of the reason is methemoglobin. What are the management? Supportive care, supplemental oxygen can be given, but not, the cyanosis does not improve with the supplemental oxygen. You have to get rid of your methemoglobin, then only it will improve. How do we reverse this reaction of oxidation? By giving methylene blue. So the methemoglobinemia treatment. First, you'll just look at the methemoglobin reductase. What happens in vivo in our body is, what happens is, we have the enzyme called methemoglobin reductase, which actually reduce the ferric form into ferrous form automatically. That's why we don't develop methemoglobinemia. But in a person who develop, or patient will have a reduction in this enzyme methemoglobin reductase, or they have a congenital methemoglobinemia, idiopathic, they can all develop this methemoglobinemia because this methemoglobin reductase is not present. Okay, so your ferrous can become ferric. So how do we reverse it? By giving methylene blue. What does methylene blue? Methylene blue reduces ferric form to ferrous form, thus reducing the number of methemoglobin. That is just an extra information. And for completion's sake, we will talk about IV regional anesthesia, Bier Block. Not commonly done. I personally have seen only once my specialist doing it. It's not commonly done, but in Mysora, they have talked about it a lot. I was told that in a battlefield, in a place where you don't have much of anesthesia equipment, it is commonly practiced, especially in a war places, battlefield, especially in Gaza. One of the specialists who just recently came back said it is sometimes practiced there as well. So it's called Bier Block. This is the picture of it. Look, you must have a BP cuff with a double cuff tourniquet. It will be inflated to a different pressure, and at the distal part, your LA will be infused to a certain amount. You previously prelocaine being used, prelocaine, but now we are using lidocaine. Prelocaine because the issue of the metabolite or toluidine. That's why we're going away and using lidocaine or lignocaine now. So these are just extra information from Mysora. The mechanism of action, distribution anesthesia will be entire extremity distal to the level of tunicate. Let's say if tunicate is here, the LA will be infused and accumulated over this whole region, and this whole region will be numbed, can undergo operation. Two mechanism of anesthesia: peripheral infiltration block, direct anesthesia, LA budding, bare nerve ending in the tissue, mean direct action potential conduction, nerve block conduction. Conduction block, indirect anesthesia, LA being transported to the substance of the nerve via vasa nervorum. This is all extra information. Block duration determined by the duration of inflation of tunicate. The indication and contraindication, I'm not going to go into it. You all can read. What I want to talk here about this, the local anesthetic choice now is lignocaine, which is lignocaine 0.5%. Okay, not lignocaine 2%. This is lignocaine 0.5%. The normal lignocaine VF is lignocaine 2% with 20 mg per ml, whereas lignocaine used in Bier's Block is lignocaine 0.5%, 5 mg per ml. Quite fast onset. Termination of anesthesia after tunicate deflation time at 5 to 6 minutes. Recommended maximum dose is 3 mg per kg because we can't add on with adrenaline. We're going to give it directly IV large doses. If you give adrenaline, patient going to develop arrhythmia. Okay, no need to use long lasting LA. Duration of analgesia is determined by the duration of inflation of the tunicate. That's why we not using Ropi or Bupi. We want to infuse the LA and we want the effect to be there as long the LA being infused with the tunicate being inflated. Summary, these are all from Nysora. I found a very good single sheet info, so I'm just going to share with you all. This is just a summary of all that we have talked about for your own reading. I will share it in the group in the PDF form as well. Questions, these are all repetitive questions of what we have discussed. So I hope you all will try it on your own. So for your better understanding, please do it. I didn't go into the individual LAs. This is your homework. Please sit and do this compare and contrast lignocaine, bupivacaine, ropivacaine in terms of PK and PD, toxic profile, everything. Okay, that's all.